Red Bull makes you.
The dragon one? Yeah, that one's really good, but I really come back.
Good morning, Vietnam.
It's one of the sweet.
Hello, hello.
Yeah, that'd be weird. I used to work at Big D. I honestly don't like it. There's it. You say you don't like it. I don't like the flavor.
My daughters say that at Bigby, that their coffee is too sweet. They just take the syrup and. I don't either. That's why. I just drink water.
I don't like some of them are, some of them aren't. It tastes like dirt water.
Dirt water. That doesn't sound good. Okay, Miss Bree, are the slides moving?
Yep, everything's good.
Good. We are on chapter 10 or 11. I think it's 11. Yeah, 11.
Dr. B, did anyone talk about the API?
So it turns out with Proctorio, the program proctors you, but you still have to have a proctor proctoring the exam, which in the proctoring video that I had to do and waste lots of time doing, they never mentioned that. And I checked my copious notes that I took because I took notes all the way through it and it's not mentioned once. So I'm going to give you times when I'll be available to be a proctor. And then Mindy said she can be a proctor as well. So my understanding is that the system is very sensitive. So if you look around the room at all, yeah, I'll get a note saying so-and-so looked away. To which I said, well, she's tying her shoes? I mean, looked away. Looked away what? Her dog came in the room and she's petting her dog? Looked away could mean nothing. So so-and-so looked away. If it gets to the point that you're supposed to stop the test and start again, but so that's the way we're going to do it. I will give you a list of times and that's the way we'll do it.
Does it have to be you that flags us then, or is it the actual site itself that was flagged?
The software flags you and sends me a note. So if I want to stop the test at any time because the software says that Haley just can't keep her eyes on the screen, Haley's obviously cheating because, you know, she can't pet her kitty cat or deal with her little sister. Her little sister comes in and says, play with me, play with me, play with me, like little sisters are prone to do. Or if, you know, I don't know, your ceiling paint starts falling on your head or something like that, you look up. It'll send me a note saying so-and-so is looking around. Or it says, is disengaged from the screen. Disengaged from the screen. Big deal. You look down at your coffee cup, you can grab it and drink some coffee. So I'll kind of look at that and go, yeah, whatever. So now if someone is trying to get off the screen to look something up, that's another story. But if somebody's looking around, I'm not going to stop the test. So that's the way we're going to do it. So I will talk about that tonight. Very good. It is time to get started. We're going to hopefully finish our discussion of sickle cell disease. The next chapter is hemochromatosis, which is pretty simple chapter, pretty straightforward. Chapter after that is cystic fibrosis, the genetics of which are deceivingly simple, when in fact the disease is very complicated. Even genetically, it's actually not as simple as it's advertised. Okay, so we will jump in with 2 feet. Let's pray first. Father, thank you that this day is warmer than the last few days have been. We pray for our baseball and softball players as they are on the field. We pray for those who are sick. Please heal them. Thank you for this time. For those who are away, we pray for traveling mercies. And now for us, we pray for learning mercies as we dive into sickle cell disease. In Jesus' name, amen. To review from last time, pathologically, what are the 2 main features of sickle cell disease? Vaso-occlusion. And what? Hemolysis leading to yeah. What happens when you don't have very many red blood cells? What's that called? Anemia. Vaso-occlusion, and yes, hemolysis is all part of that. Unconjugated bilirubin, scleral icteration, and all that. Yes, that follows from the vaso-occlusion. But because your liver and spleen are chewing up lots of red blood cells, and because red blood cells that get stuck are fragile, they get damaged, you suffer also from anemia. So your vessels are getting plugged up, and so you have various tissues, various organs that experience ischemia. And then you have anemia. And if any of you get the opportunity to take care of someone with sickle cell disease, one of the things you'll be spending a lot of time doing is pain management, because when the sickle cell crises occur and there is vaso-occlusion occurring in particular organs, they can experience just racking pain. Racking pain. So pain management will be important. So the condition is inherited as an autosomal recessive. If you are heterozygous, however, you will still have sickling. And I have a picture that I found online, and I'd like to share that picture with you, if I might. So here, for example, let's get that here, and then let's pull that up. Okay, yes, you're thinking about it. So here are your normal looking red blood cells, and then Can we agree that these things here just don't look normal, do they? Those are your cells that are showing the sickling trait. Now, as you look at the field of cells, most of them look normal, don't they? But only a few of these can actually plug up those small capillaries, because remember, these cells are not only poorly shaped and fragile, they're also sticky. So that's what causes the vaso-occlusion. That's a very important thing to remember. So vaso-occlusion and anemia. All right, so we talked about where you'll find this. You find this in people descended from ethnic groups that lived in areas where malaria is endemic. The allele, when it is present in one copy, provides some resistance, innate resistance to malaria. And in the United States, some 2 million Americans, usually those who are descended from ethnic groups that originate in these areas here, those are the ones that will carry the sickle cell trait. So it is detectable at birth. So it is screened for now in all states and newborns. Kids usually will not show any sort of symptoms because their fetal hemoglobin is still expressed after they're born, and that fetal hemoglobin decreases gradually as the adult hemoglobin replaces it. So it's about 5 months of age where the fetal hemoglobin levels have really dropped, and the adult hemoglobin levels have now exceeded. And you will start seeing chronic multiple infections, pain, anemia, failure to thrive, enlargement of the spleen, swelling of the extremities, toes, limbs, dactylitis, things like that, that result from the vaso-occlusion. One of the treatment strategies, in fact, is to use a drug called hydroxyurea. Hydroxyurea will reinitiate expression of the fetal hemoglobin. Because the fetal hemoglobin doesn't cause a sickling, the fetal hemoglobin can swamp out the mutant form of beta globin, and that fetal hemoglobin can help someone live relatively symptom-free. That's the strategy behind using hydroxyurea. We'll get to that in just a bit. So the patient will have a so-called sickle cell crisis. And the sickle cell crisis is caused by occlusion of small vessels, typically, not so much big vessels, small vessels that feed the tissue beds, so the capillaries that feed the tissue beds. That ischemia will cause anywhere from severe abdominal pain. You might even see signs of either transischemic attack or stroke. They might be very subtle. You might see absent seizures, in fact, in some cases. Acute chest pain, you may see renal necrosis, ulcers in the legs or even the arms as well, priapism in males, and then vision loss due to vaso-occlusive infarction in the central retinal artery, usually in the eye. Those vessels in the eye, of course, are very small, so they are very prone to getting plugged. All the clinical manifestations usually can be traced to hemolysis, vaso-occlusion. So after a crisis, you're going to usually have jaundice. And because of the high bilirubin levels, that bilirubin, as it starts to get put into the bile, that can precipitate out. You can have a gallstone. And these can cause death of various tissues. In fact, it's very common for people with sickle cell disease to have a non-functional spleen by the time they're in their early 20s, because the spleen essentially becomes ischemic and the spleen just dies. Consequently, without a spleen, your ability to resist infection from certain encapsulated organisms goes down. Consequently, it's extremely important for people with sickle cell disease to get their childhood vaccinations. And also to be vaccinated against pneumococci and other types of organisms, because encapsulated organisms, Streptococcus pneumoniae, organisms like that, they will tend to cause disease very easily in people without a functional spleen. The tissue death sometimes will result in blackening of certain organs, certain places. Tissues will tend to fall off. You may get people who lose toes or something like that. Now, in addition to the beta hemoglobin S allele, so remember the wild type is the A allele. The major sickle cell disease allele is designated by a capital S. There is a different allele where there's a mutation in a different part of the beta globin gene. It also can cause sickle cell disease, and that is called the C allele. The C allele. Individuals can be heterozygotes, where they have the S and the C allele, and that causes so-called C disease. This tends to be a milder form of sickle cell disease. And folks that have two copies of the S allele, they'll tend to have autoinfarction of the spleen in early childhood usually. So clinically, there's a hemoglobin difference between those that are homozygous and those that are heterozygous. These patients will tend to have higher hemoglobin levels than those who are doubly, who have two alleles essentially. You can see their hemoglobin levels in general tend to be low on the average. Usually below 9 in general is usually considered anemic. Leading cause of death among people with sickle cell disease is something called acute chest syndrome. And that's just simply due to the blockages occurring in the lungs. So you get pulmonary embolisms or in the coronary vessels of the heart. So the person has a heart attack. The signs of this acute chest syndrome can vary among people. You can see them very often on imaging, but you might not. Simply because these are clots in very small vessels and they might be spread out such that they're just very hard to see in imaging. If they occur together in an area, you'll see them. If they're very spread out, you may see kind of a salt and pepper sort of thing, but it'd be hard to tell that about background on some machines. So the acute chest syndrome, that is probably the worst crisis you can have, and that is responsible for death in many of these people with sickle cell disease. So the enlargement of the spleen and the liver are pretty commonly seen pretty early in the lives of people with sickle cell disease. Because the vessels in the liver tend to be bigger, and you tend to have vessels that lead into that larger portal vein, the liver is more tolerant towards these sorts of things, whereas the spleen is full of all kinds of nooks and crannies. Did you guys see in AP Any sections of spleen, slides of spleen? No, yes? Yeah, spleen, when you look at a slide of spleen, liver has that very regular sort of look. They look like bathroom tiles. That's kind of the way I think of it. They look like hexagonal bathroom tiles, and they're organized usually around channels, usually. Whereas spleen is just kind of take your spaghetti and throw it on the wall, essentially. And that's kind of what spleen looks like. There's lots of tight spaces in spleen. So spleen's not going to be very tolerant of a vaso-occlusive sort of event. If this occurs in the brain, then your patient can have paralysis, seizures. They can have palsies that involve cranial nerves, Bell's palsy, things like that. Changes in mental status, speech can go south. And some research from about 3 years ago shows that in some patients, these little strokes, they're small, so small you can't tell the difference, but as they accumulate over time, now you start to see these sorts of events kind of occurring very gradually. Stroke risk occurs either very early or later in life. So you have kind of a J-shaped curve in some ways. And priapism, unfortunately, in males with sickle cell disease, because again, the vessels within the penis and in the erectile tissue are small. So they're easily blocked. And if you don't treat this, this can cause impotence. You can also get necrosis of the bones of the upper and sometimes even the lower leg. Upper leg is more commonly involved. Renal failure, again, small vessels, easily blocked. Yes?
What is impotence?
What is what?
Impotence.
Impotence?
Yeah.
And not able to have children. Not able to sire children, shall we say. And in kids, monitoring their growth is extremely important. Ulcers of the lower extremities, again, because of blockage of skin capillaries, damage the skin. So people with sickle cell disease, you need to be checking the skin of their feet, the back of their legs. They may have paresis in their lower limbs. You need to be essentially doing the old tuning fork, the tuning fork test, where you whack the tuning fork, you put it on the toe, and then move up the foot to make sure that they have vibration, and then toothpick, you use a toothpick, you just scratch the toe and then go up to make sure they can feel. And this is kind of what I was saying before. Some patients may not have clinical symptoms, but damage may accrue gradually and then cause changes that may occur all of a sudden. Others may really not show any symptoms, but under certain circumstances, like high altitude, or if they are subjected to conditions where their tissues have very low oxygen tension, say they run competitively, say they're a sprinter, say they're a competitive swimmer or something like that, say they do competitive diving, where you go down in the body to hold your breath for quite a while, where you come back up, something like that. Those are conditions that may elicit a sickle crisis, because remember, the polymerization of the mutant hemoglobin occurs much more usually, much more typically, much more rapidly, much more easily in a low oxygen environment. Because of that, these particular kids may need to forego certain types of activities. You want to hike Kilimanjaro? No, you probably should. You might want to stick with the Bunny Hills or something like that. So ice climbing Kilimanjaro or something like that. One of the easiest signs to see in a person with sickle cell disease if they're having a crisis are the hands and the feet. They get dactylitis. So usually you'll see swelling of the fingers, redness of the fingers, or the toes for that matter, the so-called hand-foot syndrome. They may have other symptoms that are shown here, but they may not. If you do a complete blood count, the cells may look normal on a smear. If you drop the oxygen tension, however, now sickling may appear in spades. So there is a test for sickle cell disease where you can do a smear in a low oxygen environment. Labs essentially will take the blood and they will usually blow CO2 into it, then do the smear. While the smear is being streamed to CO2, you have to do it quickly because it dries quickly with CO2. But most lab techs are very good at that sort of thing anyway. Put the drop on, and then because it dries so quickly, you can look at it right away. These are tests that are very easy to do. There is also a test that uses gel electrophoresis because the migration of the S allele beta globin and the A allele hemoglobin is different in an electrical current. Not every lab is set up to do this. Usually, if you send the blood to a hospital, most hospital labs will have the equipment to do this. Your usual doctor's office lab may not have the equipment to do that. So for example, Henry Ford Allegiance, Townsend in near Vandercook in Jackson, they have a diagnostic lab in the basement. When I went there this summer, I was chatting with the lab tech and I said, if someone had sickle cell disease, could you do the electrophoresis? She said, well, we can do the smear here. But for electrophoresis, we'd have to send them to Fort Memorial in town because their lab's a lot bigger than ours. But she said if it was positive on the smear, we'd send them over there. They've got the goods to do that. The type of equipment that can do that today is the old days used to, you would pour a starch scale, you'd put it in, you'd run it, do an activity stain, and the whole thing would take about 4 hours. Now, you can put in these machines and you get a result in about 20 minutes. So this type of result is much easier to achieve today. If the disease is not diagnosed and healthcare workers don't know what to expect, mortality rates are really high. That's why screening for this is automatic. When the baby usually gets its first blood sample, that's one of the things that's screened for, sickle cell disease in all states in the union. Also in Europe, many European countries do that too. You should screen before 6 weeks of age. So if you don't get screening right in the neonatal unit at the hospital, then you should make sure that there's a draw set up where hemoglobinopathies are tested for, particularly if there's a family history of it. So sickle cell disease is the one you see most often. There are others like beta thalassemias, alpha thalassemias. Those are also hemoglobinopathies. There are easy tests for those as well. And if the kid has them, they can get started on hydroxyurea. It is not hugely common to see people with a thalassemia plus the sickling allele. You do see it though. If you work in a small town clinic, I doubt you're going to see that. So thalassemias are usually mutations in either the beta or the alpha globin genes that decrease the amount of the protein product that's produced. Therefore, the amount of hemoglobin you make is low. So beta thalassemias make low amounts of functional beta globin. Alpha thalassemias make low quantities of functional alpha globin. And occasionally you get somebody who has both. You get the sickle allele with low amounts of it. Now, if that's the case, say the sickle allele is the one that doesn't make very much of it. In that case, your disease is not going to be very severe. If, however, you have the heterozygous situation where you have a beta thalassemic allele, so wild type beta globin, which don't make very much of it. You have the sickle allele, which makes normal amounts of it, but it's not functional. You can see that this sort of situation is going to cause you to have pretty severe disease. Don't see that very commonly, but it does happen. Thalassemias you find typically from people who are descended from Mediterranean ethnic groups. Greeks, Turks, a lot.
Question. So like, I know you said that like they usually tested before 6 weeks. Is this everybody or just
Everybody.
okay? Because
Yeah.
I know that when I came here, I was asked to get a sickle cell test, and my pediatrician was like, "There's no need for you to get one. If I'm not gonna get it."
Because it has symptoms,
Yeah.
I know.
Yeah.
That was for sports or they're required to, that's NAIA rules. Now, if your doctor signs off and says, oh, just, then that's as good as a test to them usually. I've been taking care of Natalie since she was knee-high to a grasshopper or something like that. I hope Earth knows that some rubbish like that or something like that. Maybe it's true. In that case, essentially, you had symptoms long ago. Also, there's other blood work that the doctor has done on you in your 18, 19 years of life that would have showed that you had this sickling allele, and there's no evidence whatsoever that you don't have it. So yeah, it's right. It's a waste of time for you to have it, but rules are rules. Yeah. So your doctor basically said, shouldn't have it. Don't waste it, don't bother me. Go away. So usually for NAIA, that's what. Now, if you went to an NCAA school and you're playing basketball for them, you have to have a test. Yeah. Your doctor's word, oh, I don't care. Or you go to the university physician, and the university physician takes your blood, runs a test, then that's fine, but you have to have a test in that case. Yeah. NAIA will buy the word of your family doctor. NCAA will not. They've had not only people actually drop dead on the pitch who had undiagnosed sickle cell disease. That's why they demand the test. Yeah. Yeah. Which.
I'm just curious because it was like they want you to have like you testing. But I think it's because he's like said that usually like with people like me.
Yeah.
Because of the like I think that's what it was.
In the case of the soccer player, I forget what school the guy was at, but he was on his mother's side had his mother's side was of African descent, but she was of a lighter hue. She didn't have the dark hue. So turns out she carried the sickle allele, but she was very healthy. He got it and he was very healthy. Like, for goodness sakes, he played college-level soccer. But he got to a point where he was just running. He had a crisis and happened to be chest syndrome, and he had a heart attack and he died. And because it was undiagnosed, things could have been done to prevent him from having that crisis. And the school got sued, and someone else got sued, and lawyers got very rich, and they made that rule, essentially. So that's why the rule exists. All right, so how do you manage someone with sickle cell disease? Well, first of all, you should look in their history, because you have their history in front of you on your laptop usually nowadays, or your iPad, or whatever you bring into the visit with you. And if they do have it, then you should ask them whether or not they've had a crisis and how long ago their last crisis was. If they know the sorts of things that bring on crises, they should be importuned, that means begged, to avoid those things that they know will precipitate a crisis. Again, pain management is really, really big. If you're going to use opioids as part of your pain management, you have to make sure that you are asking the right questions, make sure that there's not any sort of sign of addiction or something like that. So the trend now is to try and stay away from opioids as much as you can. But opioids are the best thing out there, frankly, to relieve pain. So essentially, because when a vaso-occlusive crisis occurs, the pain is really substantial. So having something essentially at the ready. I know some clinicians who will just write scripts for someone and say, don't fill this until you have an event. If you have an event, then go get it filled and use this to deal with the pain. Or just get it filled and have it ready. Just don't take it unless you really need it or something like that. If the patient gets sick, they don't have a spleen, so they're susceptible to certain types of infections. So can't emphasize this enough. They have to stay current with their immunizations. And they need broad-spectrum antibiotics should they present with a fever. That is really huge. Really huge. So in your vitals, temperature, you should look at that temperature. You should also look to see how the blood vessels look, things like that. If they have a crisis, you also need to seek immediate medical attention to prevent complications. That's really the biggie here. So this just tells you essentially what sort of tests they need to have and what have you. And those are just things that pretty standard fare. No big deal there. Now, recently, it turns out that if someone is having these vaso-occlusive crises, a couple of hematologists got the idea, since the sickling red blood cells are causing the problem, why not just give them packed red blood cells? Swamp out the sickle cells. The good red blood cells won't be sticky, and the other sickled cells will be fragile. They'll tend to undergo hemolysis anyway. They'll have enough red blood cells to feed the tissues, and because the sickled cells will be swamped out, you'll be less likely essentially to have some sort of vaso-occlusive crisis. Others objected. They said, you've got blood vessels, you're going to shove more blood through that? I don't get that. Anyway, this strategy, it turns out it works. So there was a study, it was done at It was a multi-center study. It was the head group was Mount Sinai Hospital in New York. That's upstate New York. And there are other centers around the East Coast. There's some centers, I think, in fact, U of M participated in this study as well. And lo and behold, this seems to work. So by giving sickle cell patients packed red blood cells, so you centrifuge the blood, you get rid of the plasma, you get rid of the Buffy coat, and then, see Kathleen?
Yeah, we'll see ya. I don't know.
Then you give them this transfusion slowly, gradually, that brings them out of their crisis. And because after they've had one crisis, it makes another crisis really likely, increases the risk for it. This drops the risk of having another crisis pretty precipitously. So this seems to work. Now, the downside is that this tends to load you up on iron. So if you are giving patients lots of packed red blood cells, then you might start to get iron accumulating in organs. And iron, you've got good storage methods for iron, but if your storage methods get overwhelmed, you can start to get iron crystals that form in organs that can cause permanent organ damage. Not to mention it can seriously plug you up and cause other kinds of problems as well. So a liver biopsy is a really good way to determine whether or not the liver is getting overloaded with iron. Liver MRIs can look for iron bodies in the liver to make sure you're not really overdoing it. And then there are some drugs you can give that can grab iron and pull it out of the system. And these types of iron chelation sorts of treatments are a bit of a pain, but they can definitely de-iron somebody quite well. So that's something to consider as well. Now, hydroxyurea is one of the most common drugs that's used for sickle cell disease. It's been used since 1998, so it's an old drug. It induces the production of the fetal hemoglobin. Also tends to lower the white count and diminish inflammation within the vessels. Also, on the average, the drug is pretty well tolerated. It's not that it doesn't have its side effects, it does. But because people are taking it all the time, it's relatively well tolerated. So lots of work has shown that hydroxyurea will reduce the risk of the crises. There's a new drug that binds the so-called P-selectin on the surface of red blood cells that sickle. When these red blood cells sickle, this P-selectin is found at the tips of the red blood cells that causes them to stick to the endothelial cells. So this particular antibody, crizanlizumab, even though it showed promise in clinical studies, FDA approved it. It's really expensive. It doesn't work that well. So crizanlizumab is a bit of a letdown. In fact, the medical letter said, for such a great price, this drug delivers little. which is a pretty big indictment of a drug from the medical letter. And that's one of the main drug evaluation rags for the medical profession. So medical letter was not very impressed with crizanlizumab. It's a good idea, but the drug just really didn't deliver. Hydroxyurea is a lot cheaper and has a very good track record. If someone has a bone marrow transplant, that can cure their sickle cell disease. Now, there's two downsides to this one. They find a good match. Two, they have to survive the procedure. Surviving a bone marrow transplant is not easy because you have to wipe out the bone marrow that you have. You have to give these really nasty drugs that wipe out the bone marrow, and you subject the patient to high-level gamma radiation to wipe out the bone marrow. Then, once it's clear the bone marrow has been wiped out, you transplant the bone marrow and you pray like mad that number one, patient does not get severe graft versus host response. Number two, that they don't get a disease. Because if they get a disease, they don't have any white cells to fight it off. So there is and the heroes really of transplants are nurses, transplant nurses. As the nurses are the one to make sure that the patient stays away from germs, that they stay in a germ-free environment, that they take all the medications that they're going to need to take, and also monitors to make sure that the new bone marrow is working and that graft versus host response has not occurred. So kudos to transplant nurses. What do you do if you have a family that has a hemoglobinopathy in their family history? You get a family history. Number two, if it's clear that person's at risk, you recommend then for genetic counseling. Now, after conception, you can do amniocentesis or chorionic villus sampling in order to determine if the baby is going to have sickle cell disease. Then you essentially know what to expect. When it comes to managing sickle cell disease, this is definitely the best time to be alive because it's clear that medicine knows more about managing this disease well than it ever did in the past. There were lots of mistakes made in the past and a lot has been learned. Having said that, managing these patients requires a high degree of attention to details. Very good. So, all right, so the sickle cell disease is caused by a mutation in the beta globin gene. It will cause the hemoglobin under low oxygen tension to form a fibrous rod-like polymer that deforms the red cells. It makes them sticky as well. Sickle cell disease is screened for in newborns before they are 6 months old. You can diagnose this with a low oxygen tension smear or electrophoresis. The trait is usually silent at first because of the fetal hemoglobin. It's always exacerbated by any event that diminishes the amount of oxygen in the bloodstream. Mortality is due to the number of vaso-occlusive events. Packed red cells can decrease the number of these events. And the surveillance guidelines can be very individualized based on the severity of the disease and on the patient's age. And the drug of choice is hydroxyurea, which does diminish the vaso-occlusive episodes. And here are some references if you are so inclined. The Merck Manual online, by the way, Merck Manual is free. The Merck Manual article on sickle cell disease is quite good. So if you're interested in reading more about this, take a look at Merck Manual in particular. CDC has a nice little page. CDC has stuff both for healthcare professionals and also for patients. The patient stuff too is really well done. You can tell if patient stuff was written by a physician trying to write to patients. Doesn't quite work sometimes. These are written probably by professional writers who take what the physicians give them and then rewrite it for patients so they can understand it. This was the clinical trial with crizanlizumab, and it looked very hopeful, but then clinical experience said, I don't think so. Questions about sickle cell disease? No? Before we go any further, what do we have on Friday? An exam. Have you submitted your questions to the website? Some of you have. Some of you, in fact, have submitted some pretty darn good questions, so kudos to you. Couple of you have submitted questions that are really similar, so you might want to read through some of the questions that are there before you submit yours to make sure we don't get a ton of repeats. There are a couple questions that have repeated a respectable number of times, so but those will help me write the exam. I will write it tomorrow, so by tomorrow afternoon, if you submit questions after that, I probably won't use them because I'll be writing it tomorrow afternoon. Let's look at hemochromatosis. So this is an autosomal recessive genetic disease. And it is a mutation in the HFE gene. And a non-functional HFE protein will cause increased intestinal absorption of iron. The HFE gene protein regulates iron uptake. If you have more iron than you can use, you stop taking it up. Non-functional HFE, however, causes you to take up more iron. And now you get large amounts of iron being deposited in tissues, and that can damage tissues. So among Caucasians, this will affect 1 in every 200 persons. Single most common single gene disorder among Caucasians. When do people start showing symptoms? Usually in their 40s. The iron accumulation occurs over time. The tissue damage that it causes also accumulates over time. The disease tends to be asymptomatic at first. Because females lose blood during menstruation, they lose more iron. So females, if they show symptoms, will show symptoms a lot later in life than males will. The usual complaints are pretty nondescript at first: abdominal pain, arthralgia, fatigue, and you also may see unexplained hair loss as well. Now that hair loss, if you test the hair, which you can do easily, it'll show huge amounts of iron. So if someone has these rather nondescript symptoms and they're losing hair, ask them, can you bring me some hair? Let me comb or something. We get that tested easily. And it might show severe amounts of iron. If it does, that could be a tip-off as well. Your liver function tests are going to show that the liver is starting to experience damage. Also, because the pancreas can be damaged by iron storage as well, you may start to see someone become mysteriously diabetic, even though they're not obese, they might be active, they're not overweight, and all of a sudden they're diabetic and it's kind of a type 1 type diabetes. They have to start taking insulin. You also start to get insulin darkening the skin. And if they have pictures of themselves, might look at pictures and, okay, it's the middle of winter. Here you're lily white. Now it's a lily white. Another tip off that something iron related is afoot. Some patients have heart murmurs, not as common. Conduction disturbance on EKG, also not as common. Enlargement of the liver happens, but not as common. And then you might see issues with the thyroid, reproductive system, and arthritis. Now, arthritis, your book says, is not that common. Actually, according to UpToDate, arthritis is kind of common. So that one, let's say common, not so common. So iron deposition in the skin darkens it, but increased iron also increases melanin deposition. And this disease, consequently, was at one time called bronze diabetes, since you have the darkened skin and insulin resistance. Very strange. So what sort of lab tests are you going to run? You do a regular serum iron. Regular serum iron might be increased, but it might be normal too. Then you do a serum ferritin. Now ferritin, remember, is the main storage molecule for iron. That's going to be increased. The TIBC might be normal, but it might be decreased as well. Transferrin, remember, transferrin is the major iron-carrying protein of the blood. Transferrin is going to be saturated and it will be increased. So the elevated transferrin saturation, that's one of the earliest lab findings of hemochromatosis. That usually occurs before you get any clinical manifestations. So if this runs in the family, you might want to run that test when someone comes in for their physical every time. Because iron is an oxidizing agent, because if you concentrate large amounts of it in parts of the liver, you're going to start to kill off those liver cells. If you kill off sections of liver cells, they are replaced by stellate cells in the liver with scar tissue. Pretty soon you have scar tissue surrounding sections of functional hepatocytes, but they're isolated from other islands of hepatocytes, and they have trouble communicating with each other and functioning properly. And then those scar tissue also gets lined with fat. That is fatty liver disease or cirrhosis. Cirrhosis. Also, because you're getting damage and regeneration of the liver, that increases your risk of liver cancer, hepatocarcinoma. A liver biopsy can show this quite easily. Imaging has kind of replaced biopsies now. They're not as invasive. Also, the imaging has gotten so good, you can see this sort of thing happening pretty easily. Genetic tests are available for hemochromatosis. They're very good tests too. MRI is no sensitive technique. Bedside ultrasound you can do. But MRI is kind of the gold standard. So testing, genetic tests are done from whole blood using PCR. The HFE testing, you can test essentially just for the HFE gene. That's replaced the need for a liver biopsy in some cases. If you're heterozygous for this condition, you don't develop the disease. You have to have 2 copies of the mutant allele to develop clinical symptoms. However, their blood work might be abnormal. So if the blood work is abnormal and someone's heterozygous, but they don't have clinical symptoms, don't worry about it. Don't worry about it. You'll still have to tell the provider, but you don't worry. Now, it's important to catch this disease early because of the damage it does to the liver once you start having these manifestations. So screen all adult patients who have a family history of it. Screen all adult patients who show any signs of iron overload and don't have good reason for iron overload. If they're dependent on blood transfusions and they got iron overload, they're supposed to. But if they're not living on blood transfusions and they show signs of iron overload, they show the bronzing, they show all of a sudden diabetes like that, screen it. The test is not that hard. It's not invasive, it's just blood. And it's not expensive. And you have reason to propose a test, in which case insurance will usually pay for it. Should you screen children? It's not recommended. You can, but it's not recommended. So how do you treat this disease? Bleeding people can actually reduce iron overload. It's called therapeutic phlebotomy. You withdraw blood, and that will decrease serum ferritin. So essentially, someone comes in and they have blood removed. And that turns out to delay the onset of symptoms really well. Therapeutic phlebotomy. And I think you'll agree, that's easy. You can also use chelating agents that are going to bind iron. There are intravenous agents and there are oral agents that will do this, just like what you'd use for sickle cell disease. Deferoxamine is an intravenous iron chelator. Then there are some oral agents as well. Deferiprone, that is also oral. And there's something called Deferazerox. That's also oral as well. These are medications you can give, and they will grab the iron and take it out the chute. If these folks take iron with vitamin C increases iron absorption. So you want to avoid taking vitamin C with iron. You also want to avoid eating foods really high in iron. And I will let you research foods high in iron to figure out what those are. If people have end-stage liver disease and liver transplant, there any questions about hemochromatosis? Very good. So Friday we have an exam. And after that, we'll look at cystic fibrosis, where sickle cell disease tends to be found in people of African descent. Cystic fibrosis is found in people of Caucasian extraction. So that is also a very interesting disease whose genetics, again, is more complicated than advertised. No, no. We're having a test and then you're enjoying your weekend. Okay. All right. That's all for today. Folks on Zoom, thank you. Hope to see you Friday for the exam. If not, please make an appointment at the Academic Support Center in order to be able to enjoy taking the exam at your leisure. Yes.
Thank you.
Case studies.